Welcome to today's webinar hosted by VitaFlow, titled Nephrogenic Diabetes Insipidus, Medical and Nutritional Management. A few housekeeping points before we get started. The webinar will last approximately 1 hour and will include time for questions at the end. If you would like to ask a question, please use the question feature on your GoToWebinar toolbar. All questions will be screened and a select number will be answered by the speakers at the end of the presentation. The webinar will be recorded and will be available on VIA in 2 to 3 weeks. You can access PDFs of the presentation slides, a certificate of attendance, and a self-reflection tool in the handout section of the toolbar. The views herein are of the presenters and do not necessarily represent VitaFlow's views. The material herein is accurate as of the date presented and is for educational purposes only and is not intended as a substitute for medical advice. VitaFlow is delighted to introduce our speakers for today's presentation. Firstly, I'd like to introduce Professor Detlef Bockenhauer, who is a Professor of Pediatric Nephrology at the UCL Department of Renal Medicine and an Honorary Consultant Nephrologist at Great Ormond Street Hospital for Children NHS Foundation Trust. He studied medicine in Germany and trained in pediatrics in Hamburg and in New York City. He subsequently trained in pediatric nephrology and renal physiology at Yale University. He has worked as a clinician and academic in pediatric nephrology, first at Yale and since 2004 at Great Ormond Street Hospital, with a special interest in the molecular basis of kidney disease, inherited kidney disease, and tubulopathies. Secondly, we have Louise McAllister, highly specialist pediatric renal dietitian. Louise has been specializing in pediatric renal dietetics for about 18 years. Since 2004, Louise has been part of the team managing children with end-stage renal disease, including those on dialysis and other renal conditions in Great Ormond Street Hospital for Children in London. Louise has recently written a chapter section within the 5th edition of the book Clinical Pediatric Dietetics on renal tubular disorders and renal stones. Louise has several other publications, including the recent clinical practice recommendations for calcium and phosphate management from the Pediatric Renal Nutrition Task Force. Louise is an active member of the Pediatric Renal Interest Group known as PRING and has delivered presentations and educational lectures both in the UK and internationally on topics related to the dietary management of kidney disease. You can see the learning objectives for this presentation are detailed on this slide. VitaFlow would like to thank both of our speakers for taking the time to present for us today. And without further delay, I'd like to hand over to you, Professor Bockenhauer.
Yeah, thank you, Catherine. And good afternoon, everybody. I'm still getting used to this new world where I give a talk and cannot see anybody in the audience. I don't know if you're sleeping or yawning or playing on your phones, but I will try to speak to you a little bit about diabetes insipidus. As Catherine said, I have a special interest in tubular disorder. And now I'm trying to move the screen, but I can't. Catherine, have you given the presentation to me? I cannot advance the slides.
Can you try again there? It should be set.
Right now, nothing is happening. It's embarrassing. We just tried it before and it worked well, but right now it's not. There we are. So here we are. It seems to have take some time. So usually when we think about kidney function, we concentrate on the glomerulus. Kidney function is sort of equivalent with GFR, the filtration. But if you look at the functional unit in the kidney, the nephron, an outline of which is here in this picture, then you can see that the glomerulus is really only a tiny little thing at the beginning of the nephron, a simple filter. And then all the exciting stuff actually happens afterwards here in the tubule. So I'm not sure if you're familiar with the proverb of throwing the baby out with the bathwater, but in my tubular opinion, that's exactly what these little filters, the glomeruli, do. They throw out a lot of bathwater and a lot of babies with this. So let me try to explain. If you have a GFR of 100 mL per minute, then that means your filters are throwing out 100 mL of extracellular fluid, the bath water that surrounds your cells, that makes sure your cells can operate fine. And this bath water obviously contains a lot of babies as well. The 100 mL per minute is 6 liters per hour, is 144 liters per day. Just think about that. And since it's usually corrected for body surface area, let's just say it's 150 liters a day. So your little filters, the glomeruli, are throwing out 150 liters of water. And in there is the equivalent of more than a kilogram of salt, plus hundreds of grams of sugars and amino acids. So who has to clean up that mess? It's the tubules, of course. They have to reabsorb virtually all of this in order so that you don't lose 150 liters of water per day, that you don't lose more than a kilogram of salt per day, that you don't lose hundreds of grams of sugars and amino acids. So your tubules are truly a reason to be grateful, because without your tubules, you would pee and thus need to drink 150 liters per day. You would pee out and thus would have to eat more than a kilogram of salt each day, and so on. So this is why I am interested in tubular diseases, and nephrogenic diabetes obviously is one of these tubular diseases. There's a whole orchestra of hundreds of different transporters and receptors involved in this complicated task of reabsorbing everything that these little filters are losing every day. And if one of these transporters or receptors breaks, then you can get one of those tubular diseases. And here, just a complicated looking slide, but I will really only concentrate here on the yellow part, this one here, which is the loop of Henle. And this is just to remind you that this is actually where concentration and dilution of the urine is initiated. It's the countercurrent mechanism in the loop of Henle that leads to the dilution of the urine. So the big black border here is supposed to indicate that this is water impermeable. So as the thick ascending limb removes salt from the tubular fluid gets diluted and the interstitium gets concentrated. And that then creates the driving force for the reabsorption of water here in the collecting duct. And that occurs via these principal cells. And this is again a complicated looking slide, but I hope I can make it easy. So this is one of those principal cells, one of those epithelial cells in the collecting duct. It's a polarized cell, meaning it's different in its makeup on the luminal or urine facing side compared to the basolateral or blood facing side. So you have a different portfolio of transporters and receptors on this side compared to this. This is what it means to be a polarized cell. And I will highlight here first the vasopressin type 2 receptor. So this is the receptor that receives the signal from the brain in the form of AVP or vasopressin if the urine needs to be concentrated. So if AVP binds to this receptor and this receptor gets activated, then it initiates this complicated signaling cascade, which you will be relieved to hear. I'm not going to go into those details, but which ends with the insertion of aquaporins, of water channels, specifically of this aquaporin 2 water channel, into the luminal membrane, so that water can now follow the concentration gradient from the tubular lumen back into the interstitium. And highlighted here then are the two molecules that are at the basis of nephrogenic diabetes insipidus. The vasopressin type 2 receptor is on the X chromosome. So mutations in this gene are the basis for X-linked nephrogenic diabetes insipidus, and that makes up about 90% of all patients with NDI. And this is why most of our patients are boys, because X-linked disease obviously will affect predominantly boys. And then the aquaporin 2 is the basis for the autosomal nephrogenic diabetes insipidus, typically recessively inherited, although there are a few rare mutations which can also be inherited in a dominant fashion. But the common basis for this is if one of these two molecules is broken, you cannot reabsorb water here in the collecting duct. You cannot concentrate the urine. And that leads then to obligate water losses, which in an adult typically would be around 10 to 12 liters per day. So it's quite a large amount of water that's being lost. And I will try to illustrate this with a case. Probably most of you, if you're listening to this, you're familiar with this. These patients typically present in the first year of life, like the 6-month-old boy who was referred because of failure to thrive and vomiting. And again, these are absolutely typical symptoms for the initial presentation. And also very typical, there was no past medical history. Specifically, pregnancy was normal. There was no polyhydramnios. So NDI is not associated with increased urine output during pregnancy because the osmotic load, which Louise will talk to you later on, is cleared by the placenta. So it's not driving urine output during pregnancy. If you have polyhydramnios, you need to think about different disorders like Bartter syndrome. On examination, he was pretty much unremarkable, but you can see the failure to thrive. His weight is below the 0.4th percentile. His height is just above the 0.4th percentile. And his head circumference is still relatively unaffected. Blood pressure was normal. Ultrasound was normal. And then the typical electrolyte profile. Hypernatremia with a corresponding increased osmolality, true hypernatremia. Creatinine is normal, 30 micromoles per liter, or if you're used to milligrams per deciliter, 0.4 milligrams per deciliter. But then if you have such a concentrated plasma, what you would expect the kidneys is to hold on to water, to concentrate the urine. But instead, what you see here is a very dilute urine with an osmolality of 83. So you clearly have a diagnosis of diabetes insipidus. And then, as you all know, the next step would be to see, is this cranial? So the brain is not making enough of this hormone vasopressin, this hormone AVP, or is it nephrogenic, meaning the kidneys cannot respond to this hormone? And in order to do so, we use this medication called DDAVP, which is an analog of AVP, but it's highly specific for the type 2 receptor in the kidney. As you know, vasopressin is called vasopressin because it makes your blood pressure go up, and that's because you have type 1 receptors in the vasculature, and they really constrict your arteries. And we don't want to have that when we do this test. We don't want to make these patients hypertensive, and this is why we use DDAVP, which only affects the vasopressin receptor in the kidney, although you have a few of them also in the vasculature, and they actually make your blood pressure go down a little bit. But that's not relevant right now. Predominantly, this really is just affecting the kidney. And we give this patient DDAVP, and you can see his urine osmolality is completely unimpressed by it. So this is a clear case of diabetes insipidus where the kidney cannot respond to the hormone. So nephrogenic diabetes insipidus. Now, how do we treat this? Well, there's a portfolio of medications that you can use. And in the first instance, these are the non-steroidal anti-inflammatory drugs. The classic one is indomethacin, but at least in our center, we increasingly use ibuprofen and celecoxib. One, because indomethacin, there have been recurrent issues with getting it, that it was unavailable for some time. But also there's some concern that indomethacin actually may be more toxic in the long term to the kidney than these other drugs. Ibuprofen is obviously very unique. There are no issues. Our experience works just as fine. And celecoxib is this selective COX-2 inhibitor where you don't have to worry about the gastrointestinal side effect. there is a misconception out there that these drugs work by reducing GFR. So, and if you filter less, then obviously you lose less water, but that is clearly not true. It's not this chemical nephrectomy, as it's sometimes called, effect. Because if that was true, you would see the creatinine go up after starting this drug. But instead, what we see is that the creatinine stays the same, or actually sometimes goes down because of the increased hydration status of these patients. And we think it actually works by enhancing proximal tubular sodium uptake. And that is actually then also a similar mechanism that we see for the thiazides, which is the other typical drug that we use, that it enhances proximal tubular sodium uptake. And since the proximal tubule is water permeable, as you increase sodium uptake in the proximal tubule, you also enhance water uptake in the proximal tubule, so less fluid is delivered to the collecting duct where it would be lost in NDI. And one observation that we have made, but I think this is true also elsewhere, is that these medications are typically very helpful in the beginning. In infancy, we can actually often see the urine osmolality go up, especially after starting the non-steroidals. There can be quite a substantial effect in the reports in the literature of patients experiencing hyponatremic seizures after starting these drugs if their water intake is not adjusted while doing so. So they can be really very helpful in the beginning, but somehow that efficacy seems to wean off over time. And whether that's because we don't increase the medication as tightly with the weight increase of these patients as we should, or whether the patients are not as good at taking these medications, or whether there's a true loss of efficacy, I'm not quite sure. But most patients really, in my experience, come off their medications with time. And the highlight then is on the dietary management, and that's what Louise is going to talk to you about. And the key, and I'm not stealing her thunder here, hopefully, but the key obviously is to understand that the osmotic load, the amount of osmotically active solutes that need to be excreted by the kidney determines total water output. So if the osmotic load is 15 milliosmoles per kilo per day, and your urine osmolality is 100 milliosmoles, then you will need at least 150 milliliters per kilo per day in order to get rid of that. Right? If you have a 10 kilo child and there's an osmotic load of 15 milliosmoles per kilo, that means 150 milliosmoles need to be excreted each day. And if the urine osmolality is 100, that means 1.5 liters are needed in order to get rid of that. If you double that osmotic load, then the patient will need to excrete 3 liters of urine per day in order to get rid of that. And if you halve the osmotic load, the patient will only need 750 mL to excrete that. So the osmotic load determines the urine volume in patients with NDI, and controlling this is therefore an incredibly important aspect of the treatment. And this is what Louise will tell you all about. In the second case here, I'm just going to highlight the complications that occur in these patients. So this is an 18-month-old boy, so a relatively later presentation, although there is a long history of coming to medical attention, brought in by the mom because of this recurrent vomiting. And it's always thought that this is just reflux, and in her desperation, the mom actually even took him to a private gastroenterologist, who does what gastroenterologists do. They do a scope, and the gastroenterologist found a normal endoscopy and said everything is fine, don't worry about it. The other problem that these patients have is whenever they're brought to A&E because of concerns about dehydration and vomiting, the first question every good doctor asks, every good pediatrician asks is, well, urine output. And the parent will respond and say, oh, actually, that's not a problem. He wheezes a lot. He has at least 8 to 10 wet nappies per day. Or if you're dialing in from the US, at least 8 to 10 wet diapers per day. And then usually the doctor is reassured because somebody with such good urine output obviously cannot be seriously dehydrated. And that's true for patients who can concentrate their urine, but it's certainly not true for these patients. They have this obligate urine output, and instead these doctors really should think that, and somebody who is clinically mildly dehydrated, this kind of urine output actually should be a concern rather than reassuring. Okay, so he comes in here again. On examination, he looks okay. He looks not obviously dehydrated. His weight is on the 2nd percentile. His height is on the 25th percentile. And he has these laboratory values. So as before, he is hypernatremic with a corresponding osmolality, and his urine is inappropriately dilute. So clearly this is diabetes insipidus as before. And he has a DDAVP test, and he has no response. So the diagnosis of NDI is made. But the problem is that there was also some concern about potential developmental delay. So he's supposed to have a brain MRI, and they don't want to do general anesthesia for this MRI. So they fasten him. They fast him prior to the for the MRI. And then what usually happens when you go for an MRI, it gets delayed. The patient is getting more and more restless. He's screaming for his bottle of water. He's difficult to calm down, and the medical team is called, and eventually they do a blood test, and his sodium is 179. And for all the doctors in the audience, I would like to take a moment now to think about, what do you do? Here's a patient who has just had a diagnosis of NDI made, who has now hypernatremic dehydration with a sodium of 179. What are you going to do? I think clearly the most obvious response would be, just give this poor boy his water bottle. Let him drink. He's crying out for it. He's thirsty as can be. He wants to drink. Then obviously you would have to cancel the MRI, but so what? That can be done at another time. The problem, I think, is that we as doctors typically have been trained that we must not give pure water in hypernatremic dehydration in order to avoid a rapid decrease in the plasma sodium and therefore get a cerebral edema. So the doctors in this particular instance decide they're going to give a bolus of normal saline, 20 mL per kilo. And he doesn't get better, so they give a second bolus, and then eventually a third bolus as he doesn't improve. And by the time of the third bolus, he becomes unresponsive and needs to be intubated and goes into intensive care. And when they repeat his bloods in the intensive care, he now has a sodium of 198. And again, think about that. How can this happen? By the time this started, his sodium was 179. And you all know the sodium concentration in 0.9% saline is 154. So you're giving a fluid that has a lower salt concentration than actually this boy's plasma. And yet you end up with a plasma concentration that's higher than it was before. How is that possible? And the answer, of course, is, well, you need to take into account also the output. You can't only just consider the input. You need to take in consideration the output, the urine. Oh, and by the way, now this boy with a sodium of 198 finally gets his MRI. They're ready for him now, and they document on it with this dramatic increase in his plasma sodium, which in the morning was probably normal, and now is 198 a few hours later. once he was extubated, he had severe paralysis. He then was transferred over to our hospital by that time for further management. And he was really a terrible sight. I mean, he could barely lift his head off the pillow. But then again, I think that's the beauty of working in pediatrics. The ability of these patients to recover from these severe insults is quite remarkable. And within 2 weeks, actually, he was walking around the ward, still had some mild muscular impairment of muscular strength, but pretty much back to normal. But again, to the problem of how can it be that by giving a fluid that has a lower sodium concentration than the patient's plasma, that the plasma sodium increased so much? And again, the focus here needs to be on the output. So this is supposed to be the patient. Ignore the numbers in there right now. And this is the fluid that we've been giving him, separated into sodium and water. It's also called a tonicity balance when you do the separation of salt and water. So we gave him normal saline, which has 150 more millimoles per liter. And he was roughly 10 kilos, so that makes it easy. So he got 600 mLs of that. So he got a total of 92 millimoles of sodium in 600 mLs of water. Okay, so those are the 3 fluid boluses of 20 mLs per kilo, 200 mLs total each that he received. But then compare this to what's coming out. He has diabetes insipidus. So he has no problems getting rid of those 600 mLs of water. That's easy. But because his urine is very dilute, it contains very, very little sodium. His urine sodium concentration is only 5. So he only gets rid of 3 millimoles of water. So the net effect is that the water balance is neutral, but he retains a net of 89 millimoles of sodium. And if you calculate that, that would actually pretty much explain this increase in sodium from 140 or whatever his sodium was at the morning to 197 at the end. So the key message that I'm trying to give here is these patients must be treated differently than your average pediatric patient. The kidneys usually adjust urine so that it matches whatever comes in. That's the whole point of homeostasis, matching the output to whatever the body is challenged with what's coming in. So usually you can throw at children whatever you want. You can give them water or normal saline or hypertonic saline. The kidneys will adjust the urine in order to match that so that the net balance is normal and you maintain homeostasis. But if you have a tubular problem, then this mechanism is disrupted. They cannot do this. So in this particular instance, they cannot get rid of all those solutes that you're giving with the normal saline. And as a consequence of that, they become hypernatremic. So you must not give normal saline to these patients. Must not, I'm saying here, if they are in hypovolemic shock, which I've never seen in an NDI patient, because hypernatremic dehydration, typically intravascular volume is usually well preserved. But if you had a patient with hypovolemic shock, then I think normal saline is appropriate. But otherwise, you really just should give them water. You must, if your kidneys cannot match the output to the intake, then you as a doctor need to match the input to the output. So if they're losing water, you need to give them water. So that's why the best treatment for this boy would have been to give him just a bottle of water. Or if you were really concerned about stopping the MRI and canceling it, and wanted to give IV fluids, you could have just given them dextrose, 5% dextrose in water. You should not give this as a bolus, because then you could really rapidly lower it. But if you give it at usual maintenance rate, then that's usually a good starting point for IV fluids in these patients. And now for the remaining 5 minutes or so, just some data from a recent study that we have done here. This was main European studies where we collected data from a total of 340 patients with NDI. A good number here were genetically confirmed, some were untested, and some did not have genetic confirmation. This is their current age, and this was very reassuring for me to see, because I wanted to get long-term information about these patients. How do they do when they're older? And you can see that we have patients up to the age of 70 years. So quite a large number of adult patients, so that we could assess what complications would be. And age at diagnosis, here at the beginning, you can see the vast majority of them present in the first year of life, even before. But there are some actually who present in adulthood, and I think these are mostly women. Women with AVPR2 obviously typically are milder affected, because they have the second X chromosome that can provide the correct instruction for the receptor. But depending on your axon activation, the defect can be more or less present. But even those with aquaporin 2 mutations sometimes get diagnosed relatively late, and to some point this probably also reflects milder mutations, which allow some residual function. With regards to growth, something that as pediatricians we always care very much about, we're doing pretty well, I think. In children, you can see it's slightly below the Z-score of 0. So, but in adults, we actually then they keep up. So it seems to be just delayed growth, and they reach normal adult height, pretty much normal adult height. So that's very reassuring. And again, if you make the diagnosis and you talk to the parents about the prognosis, I think this is important information. So they typically reach normal height. Weight, we're doing pretty good in childhood, and this is, I think, our fabulous dietitians who make sure they get enough calories, so they have normal weight. But then this was really interesting and surprising for me to see. 41% of adults with NDI are actually obese. And we have the percentage of obesity in the 28 EU countries as comparison. So in the normal population, it's 16%, or in the general population, it's 16% compared to 41% of our NDI patients. So this is something that really is interesting, I think, and needs to be looked at. And it is perhaps our focus on maximizing caloric intake in childhood by, for instance, carbohydrate-containing drinks that may drive this then in adulthood. Complications, the flow uropathy, the large volumes of urine can affect the urinary tract. So a third of patients have hydronephrosis, a quarter have bladder dysfunction, especially boys that then try to be like their peers and hold on to urine and try not to go to the toilet. They get these big dilated floppy bladders. Both of these complications were present in 12%, so that a total of 45%, so almost half of patients had evidence of flow uropathy. Emphasizing again how important it is to remind these boys to go to the toilet regularly. And then one aspect that is one of the key problems during childhood is the enuresis, the bedtime wetting, which in these patients really is better described as bed flooding. And this is something one of the parents told me, this expression, because it's liters of urine that are produced overnight. So it's not just a little stain in the bed, it's liters of urine. They really flood their beds. But again, you can tell these patients that they will get rid of this. It takes longer. Usually, I think, and nocturnal enuresis is only called this if the patient is older than 5 years. By 5 years, most patients will have achieved that. Here, the median age by which time they reached control of their nighttime urine output was between 8 and 10 years of age. So it takes a little longer to reach it, but they do reach this. And then one interesting aspect, there was a paper about 20 years ago from the Nijmegen group who did a lot of work on NDI, and they described that about a third of the patients had a diagnosis of ADHD. And it's not quite clear why they have that, but the assumption is that it's just because they're always thinking about what to drink and where's the toilet. I mean, if you have to go to the toilet pretty much every hour in order to empty your bladder, and you need to drink accordingly, then this preoccupies quite a bit of your time. In this particular instance here in this study, we didn't investigate whether they had symptoms that were consistent with ADHD. We just asked the treating physicians, do they have a diagnosis of ADHD or not? And quite a large number of patients, 16%, had this diagnosis of ADHD. And 20% had others like depression and so on, mixture of various diagnoses. We then also looked at their school attainment, and you can see that there was less patients who had a tertiary degree from university than compared to the EU28 average. Nevertheless, the vast majority of patients, adult patients, this is now adult patients, obviously have full-time employment and live independently from their parents. So in conclusion, and before handing it over now to Louise, primary NDI, so the inherited form of NDI, typically presents in the first year, and the classic signs are vomiting and faltering growth. Milder cases, where there may be some residual urinary concentrating ability, may present much later, even in adulthood. Final height is typically normal, but surprisingly many adults are obese. Almost half of patients develop flow uropathy, and in this cohort, 16% had a diagnosis of ADHD, which is much higher than in the general population. And the educational attainment with regards to tertiary education was slightly lower than in the general population. Thank you very much.
Thank you very much, Professor Bockenhauer. I'll now just hand over the controls to Louise to advance the slides. Louise, we'll continue on for 25 minutes or so, and hopefully that will allow all of your presentation to be delivered.
Thank you very much. Thank you very much for this invitation to present today on the dietary management of NDI, and I hope that this will complement Professor Bockenhauer's excellent medical overview. So my plan over the next 20-25 minutes is to initially just discuss the textbook principles behind the dietetics, the practicalities of achieving this in the acute situation and through infancy and childhood, and finally to describe the challenges in management. And I hope to illustrate this by reference to my experiences with our GOS patient population, sharing their voices and concerns, and by way of a case study. So there are 4 key areas to discuss: achieving adequate fluid status, managing the renal solute load, supporting the family through the feeding difficulties, particularly in early infancy, and ensuring adequate growth and nutrition. And in practice, these are not distinct topics, and there's a lot of overlap. So as has already been described, these infants usually present with dehydration, producing large volumes of hypotonic urine and having high serum sodium levels, as the case that Detlef mentioned, possibly even up to 170 has been reported millimoles per litre. And the disparity between the high serum osmolality and an inappropriately low urine osmolality. And the fluid volume that's going to be used in the acute situation is very much a medical decision, but is informed by the recent feeding history. So it may be that IV dextrose is needed for a short time in the acute situation, but providing adequate fluids may well be enough and not requiring IVs, along with a low renal solute load. So just to move on and discuss the concept of the renal solute load, or sometimes referred to as potential renal solute load of a formula or feed. This is a term that's really just used to quantify the amount of osmotically active substances that are present that must be excreted by the urine, by the kidneys in the urine, along with water. So decreasing the renal solute load decreases the volume of urine that's needed to carry the salt and urea. And simplistically, this can be calculated by looking at the protein content, which is metabolized to urea nitrogen, 4 millimoles per gram of protein, and a combination of the salts that also need to be excreted. A formula for estimating renal solute load was proposed by Foman and Ziegler, and we use a modified form of this in our clinical practice, looking at the protein content of the feed, the sodium and potassium, and multiplying that by 2 to account for accompanying anions. And the units for renal solute load are milliosmoles per kilogram of water, but simplistically, this is usually just described as milliosmoles. So looking at using the renal solute load, if you took a male infant, 4 months, 5.5 kilos, having a standard infant formula, this would be the relevant breakdown of the nutrients that we're going to be looking at for calculating renal solute load. And so one would have 4 times the protein content, 2 times the sodium and potassium, and that would give a renal solute load in 24 hours of 90 milliosmoles. And looking at that per kilogram body weight, we're now on to about 16.4 milliosmoles per kilo from a standard infant formula. And the relevance of this, as Detlef has already mentioned, is that if you've got a renal solute load of 90 milliosmoles in 24 hours, then if you're only able to concentrate your urine to 70, then you would need nearly 1,300 mils of urine to excrete, which in the example I'm giving here, that's a very high urine output, 10 mils per kilogram per hour, whereas the normal urine output is more like 2. And so for that reason, the usual practice, certainly in the early days, is to reduce the renal solute load at or below 15 milliosmoles per kilo. And that could be done just by restricting the volume of formula that's given. So using a standard formula, one could reduce down that volume and then give the additional fluid as water or possibly glucose polymer solution, particularly if you've presented with weight loss. And again, just to show a calculation in practice, if you were giving an infant formula, additional glucose polymer solution, then you do get a reasonable calorie intake, which could be helpful if you've had recent weight loss, and a protein that approaches the RNI. In the acute situation, you may need to reduce the renal solute load below this and accept that you're not quite reaching protein requirements. But one must remember that minimum protein requirements, such as been set out by WHO, FAO in 2007, suggest that you can get by on a much lower protein intake, maybe 1.24 grams per kilo at this age. But the problem of this does raise its head when you deal with premature infants who have a much higher protein requirement. And so a renal solute load down at 15 may not be appropriate for this group. And the challenges that such a patient presents have been summarised recently in a complete nutrition article on a patient that is under our caseload. So I thought it was useful to have a look at some renal solute loads of different feeds. So in the example I've given, we're looking at 16.4 milliosmoles per kilogram body weight. Breast milk is likely to have a lower renal solute load than this. But if you were giving 200 mils per kilo, as some of these infants may well come in on, then the renal solute load of that would be way above 20. Other formulas, if you presented with a poor weight gain, many of these infants may come in on a higher energy formula in an attempt to improve their weight gain. And you can see how much that pushes up the renal solute load. And I've given some other examples here because once again, it may be suspected that a child has cow's milk protein allergy because of their vomiting. And so they may be trialled on a different formula, which would actually make the situation even worse because of the renal solute load that such a formula would be providing. So, as mentioned, NDI cases will usually have a normal antenatal history, normal birth weight, and will often present with weight loss or poor growth, along with other symptoms relating to dehydration and electrolyte imbalance. So for the purpose of this presentation, we thought it'd be helpful to look at our most recent cases of NDI, because we've had quite a few. So we identified all those who are currently under 4 years of age in our patient cohort to see how they fitted with the standard description of the presentation. And yes, they had fairly normal birth weight. So here's our 14 cases under 4 years of age, and the Z score was fairly near normal. Moving on to look at what happened, did they present with poor weight gain? We broke down these into those that were diagnosed less than 1 month of age or at 1 month of age. And these lines represent the change in their Z score during that time, with the stars mentioning the point at which they were diagnosed or suspectedly diagnosed with NDI. So you can see that for the 4 cases that were diagnosed at or below 1 month of age, there was some weight loss prior to their presentation. Nearly 70% were diagnosed before a year of age, and once again you can follow along their trajectory of their Z score, and there was considerable drop in their Z score during that time. And the mean age of diagnosis of this particular cohort was just over 10 months. The yellow star representing a secondary NDI, secondary to Bartter syndrome. And then just following that through to represent all of our patients, you can see that the late presenters had less severe weight loss. So we also extracted some other information. This is the summary of the weight progression in terms of median weights at different age groups. And I think that quite clearly shows that those who are under 1 year of age do have issues with weight gain. So the information that we extracted on the presenting features, as reported in the medical or dietetic records of these 14 cases, very much tie in with what we've been saying are the presenting features. So 8 had poor weight gain that was documented, 9 presented with vomiting, 2 were described as projectile, 6 had a suspicion of cow's milk protein allergy, and a few had histories of being tried on anti-reflux medications and formulas. 8 were requiring periods of NG feeding initially, and 4 carried on to have gastrostomies, and 1 of the NG patients continues to be fed via NG, in that the parents are not happy to have a gastrostomy. A lot were constipated and a lot require laxative, and we've actually got 1 child who continues to be constipated and unusually is requiring IV fluids to prevent constipation and dehydration. Not many were mentioned to have thirst or polyuria, but that's probably because that's not really going to be reported in an infant, but is more likely to be reflected in poor feeding and irritability. And then a few others had other symptoms on presentation. So the challenges and issues in relating to infant feeding on presentation are partly that they will be on such a variety of formulas when the suspicion of NDI is first made. Some of these will need to be changed. Some of these will need to be worked with. The couple that we had on PM were actually premature infants. But in terms of progression of feeds, in my experience, many of these are very slow to feed orally and may require a support of NG top-ups, as those statistics showed, and may require a period on continuous feeding, particularly overnight, to stabilise their fluid status and reduce their vomiting. The challenges of breastfeeding with NDI are probably overcome initially by expressing milk to see what kind of volume an infant takes, and then possibly making up extra fluid with water on top of that. So as Detlef's mentioned, the feeding volumes may need to be high initially, as we said, not all from feed or from a diluted feed, but that once the medication started, you have to carefully monitor this, because we have had a case of hyponatremia where the medication was started, and because the child was NG fed, the high fluid volumes were continued and not reduced accordingly. And illness management plan, as Detlef has mentioned, the parents are aware that they shouldn't use or rehydration solutions if the infant's at home having diarrhea and vomiting, and that use of a glucose polymer is quite a good habit to get into, to send them home with, so that they have some way of managing acute situations. So once an infant stabilised on a reduced renal solute feed with free access to water and medication if required, the next dietetic advice is really how to progress with weaning and the introduction of solids. And the key point really is to be careful and monitoring as you progress. And our practice is to allow protein containing foods and concentrate on restricting sodium intake, building up to the type of achievable population goals as set out by SACN in the UK. And the interesting point is that if you look at, say, 1 millimole of sodium per kilo for a 1-year-old, that isn't a lot of salt or sodium, and that could easily be provided from a formula. So it's not surprising that when you start to introduce solids to a weaning infant, that that's the peak period at which you are presenting, because in this instance you could double sodium intake just by your choice of solids. So as a dietitian, we have a toolbox of advice that we can give to families, and we have a standard reduced salt diet sheet, which you're welcome to access. It's freely available on the GOS Parent and Visitors website. We also use a very good leaflet that's been, oops, sorry. Sorry. Are we back on?
Sorry, Louise, I think we went to the link by accident.
There we go. Just showed you it worked. So we have a very good a leaflet that we use that's been produced by Action on Salt, and which I tend to hand to families. But our role as dietitians is very much in education of the children as they get older as well. And so many families think that the salt is that's just been added at the table or added during cooking. And as this salt cellar shows, that 75% of our salt intake is from processed or pre-prepared foods. And the desire for salt is something that the more salt you have, the more you want, as you know, when you have your crisps or nuts when you go to the pub. And certainly this slide, I always think, explains that so well, with this mountain goat risking his life to lick the salt off the rock face. So one of the pieces of information that I try and stress to families is that they need to be aware of how much salt is in processed foods. And you wouldn't think of having a glass of salty seawater, whereas something like a can of chili con carne would have a similar kind of salt content. Similarly, families say, oh no, I wouldn't give crisps, but then you have to help them to understand that there are so many foods that would have a similar salt content. And even something like bread is something that we're not always aware has got so much salt in it. We tend to tell them to avoid high salt foods like cheese and ham and bacon and hamburgers and pot noodle type products. So these guides as to how to judge whether a food has got a high salt content can be useful, but obviously it's all portion dependent. So even though a food may have a high salt content, if you're only having a very tiny bit, then that may be okay, whereas a low salt food in high amounts may well add up. I usually tell families to download this app onto their phone so they can get used to looking at the barcodes on foods, and some of the older children enjoy playing around with that app actually. I think really the key is to get the families used to a lower salt taste, not a reliance on processed foods, flavouring the foods themselves, and maybe using some of the lower salt products that are around, like the stock cubes and the ketchup, if necessary, just to make the diet a little bit more exciting. So those are the two aspects, the fluid and the low renal solute load. And in a way, those two are not the difficult things. The difficult thing with this group, in my experience, is the feeding problems. The thirst drives the vomiting and can lead to poor appetite for food because they have such a desire for fluids. And a few years ago, I did a survey of our patient population and of patients from a few years back to ask what happened in the future. What would, looking back on your experiences, what are the issues? And I asked quite a lot of questions, including how they were managing now and what advice they would give to new parents. And the parents reported that the main issue was the vomiting, less issues to do with constipation, but still those were worries. And certainly many parents didn't say that thirst was a problem that they identified. And that ties in with this Italian paper where there's a 4-month-old child with NDI who didn't actually show issues to do with thirst until he was 2 years of age. And the feeding problems that they identified were that there was a lack of interest in solids, certainly in the first 3-4 years of life, and that they were really just wanting to drink, and that they vomited and gagged. They wanted strong flavours, and some of them had chewing difficulties. When I asked them what helped, they said, of course, the medication, and a couple of them mentioned that there were some medications that did help their vomiting, or they perceived they did, and a couple of them mentioned that a tube was quite a relief, that they could get fluid in. And I asked about their current diets, and I really wanted this so that I could reassure parents of newly diagnosed patients as to what was happening next. And most reported that appetite was then good, that although they craved salty foods, it wasn't a big issue. They tried to avoid salt. Some of them mentioned that the texture of meat was an issue, and that the fluid intake was high. But this is the bit that I really took out of it, was that, okay, you will have high salt food sometimes. It's not a big deal. There might be some problems with bedwetting or drinking more water, or constipation, but that usually they could resolve that and the child learnt from the experience. So if, as a dietitian or professional, you're trying to find advice on the management of NDI, you won't really find much in the literature. The new issue of the Clinical Pediatric Dietetics textbook has a section, and there are many support groups out there as well. A lot of these are run by parents for parents, and so they advise each other, and I'm logged on to quite a few of these rather anonymously, and I see the kind of worries that they have. And certainly it's quite hard. It's quite sad when you read all about the problems of the bedwetting and the reports of taking fluid from the plug hole in the bath and from the shower floor. There's a lot of support that's out there for parents, but I do worry because there's also a lot of misinformation that's given on those sites as well. The NDI Foundation is a support organisation which has got a lot of excellent medical information on it. The nutrition guidelines are quite extensive but are very restrictive. And so, for example, the salt content that is recommended is down to 1 gram of salt a day, which, going back to our UK SACN suggestions, that would be the amount that you'd suggest perhaps for a 1-year-old. And my concerns are that if you over-restrict salt in this population group, that you may interfere with growth. And this is a Japanese paper from 2007 where the child was having issues with their growth until the sodium was relaxed a little bit, the sodium restriction. So I feel that that really helps sum up a lot to my experience with NDI, is that the first 2 years are really challenging. Tube feeding may be required. It's anxious and time consuming for the parents and for yourself. But I would say expect some feeding issues, do not over restrict salt, and carefully monitor growth and weight gain so you don't miss any problems in relation to that. So I hope you found that case study helpful, and I'd like to thank my colleagues at Great Ormond Street Hospital who helped me pull together the information on those 14 patients and the families who've informed this presentation. Thank you.
Thank you so much, both of you, for taking us through this topic in great detail. I realise we've run just up until 1 o'clock. At the moment, I just have one question I was going to pose to yourself, Louise, and then we might finish off so that we can allow everybody to get back to their day. That one question was, Louise, when you're assessing the dietary sodium intake, do you use nutritional analysis programs to assess the intake from diet, or what method would you use?
Yeah, so in the infancy, of course, it's simple because we can, there are only a few foods involved and you've got the nutritional composition of the formulas. What I would say is not to become too obsessed of aiming for a particular figure. And certainly all the papers on assessing sodium intake using assessment programs suggest that that grossly underestimates sodium intake, because the amount of sodium that you add to food at the table and the variation in the manufactured foods in terms of their sodium content means that you cannot accurately predict their sodium intake using those methods.
Oh, great. That's useful, interesting to know. Thank you, Louise. So I think we will leave it here. And once again, I'd like to thank you both, Professor Bockenhauer and Louise, for presenting today. It was really excellent and informative, and we hope that this presentation has been informative for all of you in the audience and helped advance your knowledge in this area. So this concludes today's webinar, and on behalf of VitaFlow, we would like to thank you for tuning in today. Please take the time to complete the evaluation questions before you leave the session. So goodbye from us and enjoy the rest of your day.